Welcome back. We've been talking about COPD here in Ventura County and the grant that we've received and the extra resources we're going to be providing the community. We're going to end this segment by talking about managing comorbidities and really try and wrap up the things that we've been covering over the last hour. So our problem is that COPD is oftentimes not present all by itself. There are comorbidities, and these influence prognosis. So in general, it shouldn't alter the therapy, the use of the long-acting beta agonist and inhaled corticosteroids, but we have to treat those comorbidities as if they didn't have COPD. So the big one, cardiovascular disease. So again, as we age, this could be ischemic heart disease, or the blood vessels supplying the heart itself may be smaller. If you've had a heart attack, heart failure, if you've had an area of your heart called the atrium, this is where the conducting factors come through. So atrial fibrillation, a shaking of the heart rather than the squeezing and moving blood through, and high blood pressure. These are the major comorbidities, things that we see as we age, and this is really the most frequent comorbidity. So using a cardioselective, so something that's specific to the heart, beta blocker treatment, despite beta blockers in general blocking my treatment for COPD, these are really in the balance. These are the most effective drugs and outweigh the potential risks in patients with severe COPD. Osteoporosis, we take a look at DEXA scans. We want to make sure we know what your bones are like and initiate vitamin D treatment and calcium as needed. Lung cancer is more frequent in patients with COPD, mainly that risk factor of increased exposure to all the poisons that are in tobacco smoke and are more common, the most common cause of death, even in patients with mild COPD. Serious infections with nasty gram-negative bacteria are frequent and may require very strong antibiotics, particularly with a continued exposure to antibiotics. And then metabolic syndrome and diabetes. So particularly as America has gotten bigger and bigger, the amount of stress, your own corticosteroids blocking the effect of insulin, diabetes is a very important comorbidity. Spirometry, we need to have access to that. Your doctor needs to have access. It should become the 6th vital sign in your doctor's office, an FEV1 to FVC ratio, or an FEV1 to FEV6, the amount of time it takes to get out air in 6 seconds. This needs to be a regular part of your screening, and if you're not getting it, it's time to ask for it. And then the other is having the resources in the community through Better Breathers and others for pulmonary rehabilitation and being able to stay physically active. We're relatively fortunate here in California compared to my friends in Chicago where it's 10 degrees outside. We need to stay active, and we have that advantage here. So just in summary, to assess COPD, we need to assess the symptoms. We need to assess the degree of airflow limitation with the spirometry. We need to look at the risk of exacerbations and reduce them with some of these more preventive medications, the inhaled corticosteroid, LABA combinations. And we need to treat the comorbidities, the heart disease, the diabetes, depression, osteoporosis, to stay a step ahead. So to prevent and reduce the healthcare costs, we need to treat these exacerbations. We want to minimize their impact on your life by providing early access to care. We want to prevent the development of subsequent exacerbations, and we want to look for the comorbidities. When you go into your doctor, make certain that they're doing a complete assessment. Ventura, time for you to get moving.